Welcome to SMA's Southern Medicine podcast. Practicing medicine in the southeastern United States presents unique challenges for healthcare professionals. The South's heavily rural population and limited resources require medical professionals to be more resourceful in their approach to providing quality care. SMA's Southern Medicine podcast addresses these issues by drawing on the experience of healthcare leaders who provide a multi-specialty, interdisciplinary team approach to medicine for the purpose of providing better care for the Southern patient population.
I'm Chris Morris. I'm president of the Southern Medical Association, and today I have the honor of speaking with Dr. Chris Jackson from the University of Tennessee Medical Center in Memphis. And Dr. Jackson is going to be giving a talk at our meeting this fall, and it's a topic I think that will pertain to a lot of different specialties. Why don't you tell us a little about the topic?
Thank you so much for that warm introduction, Dr. Morris. The topic for the talk is perioperative medicine. So as I call it, beyond the OR, how do we do perioperative medical management? And the hope for this talk is really to think about perioperative management in really three different areas. So that's perioperative optimization. So before the OR, what can we do in terms of proper risk stratification and setting our patients up for success? In the OR, what are things that we can make sure that our surgical colleagues know from the medicine perspective that's going to allow that patient to have hopefully a seamless perioperative experience? And then after, what are our considerations medical management-wise and otherwise that our surgical, anesthesia, and other colleagues should be on the lookout for, again, to make sure our patients have optimal perioperative outcomes?
Well, let's start off a couple of questions. First on the preoperative thing. One of the things as a rheumatologist is that we've had a whole host of different things presented to us by our surgical colleagues before our patients get operated on regarding some of our medicines. And a true story, I had actually presented the information about stopping a certain medication preoperatively to a surgeon, telling him that he shouldn't. The surgeon read the article and said it was a fascinating article, but I don't believe it. How is it that medications can have an effect on the success of surgery?
That's a great question, Dr. Morris, and I think your surgical colleague's response highlights a few things. Often in the perioperative literature, we have not necessarily had always great randomized control trials to truly say this is what we should do or this is what we should not do. But just because we don't have such trials doesn't mean that we still don't need to act on the best evidence that is available to answer the questions that persist. So when I think of medications, I try to tell people that the whole state of surgery in and of itself is its own unique physiology. You know, our bodies are not used to necessarily being put under certain anesthetic medications, having our breathing, our circulation completely, taken over by what the anesthesiologist is doing to guide us through a surgical period, which in and of itself is a body stressor. And so in thinking about that, even some of the medications we use, we have to recognize that a surgical state is not what our patients walk in and out of each day. A simple example could be even the use of ACE inhibitors. ACE inhibitors are wonderful medications for our patients that have heart failure, for our patients that have chronic kidney disease with proteinuria. But we also know that with certain anesthesia medicines and the possibilities of blood loss, that intraoperative hypotension and the development of acute kidney injury after surgery could portend poor outcomes for our patients. And so while this medicine is great in a preoperative setting, it may not be ideal in a postoperative or intraoperative setting, because again, we're dealing with a unique set of circumstances that our body is under where homeostasis is disrupted. With rheumatologic medications, like you mentioned, I'm thinking of the JAK2 inhibitors and some of our immunomodulatory agents. We know that during surgery, it is a stress response and our body is trying to mobilize, both inflammatory cells, cells to, fight against infection. And so you could imagine that continuing medications such as JAK2 inhibitors or continuing certain immunomodulator agents might not allow our bodies to be able to respond appropriately, such that if there are complications after surgery, our bodies might not be able to wall off that infection as easily, or might not be able to mount the immune response to let us know that there's something that's occurred after surgery. So it's a part of really just shifting our focus and recognizing that, again, the body desires homeostasis, but when we talk about surgery versus pre-surgery, those are two different states. And therefore, we have to approach our idea of how we look at medicines based off of which state we might be in.
Another interesting thought I had was in a 3-year period, I had both of my shoulders worked on a couple years apart. And when I was going for my pre-op evaluation, I was shocked at how different the preoperative laboratories and x-rays and everything were ordered. Is there any, we've learned from years in the past what have been done, and things have not, unfortunately, some surgeons, basically that's their set thing, or some anesthesiologists have a set pathway, and it's because that's the way they've been doing it, and that's the way they were taught. Is there some sort of way to look at what's the right approach to pre-op evaluation, and how should we be looking at that?
Another great question, and something that comes up all the time in my practice. One thing I teach my residents in terms of perioperative laboratory testing is if you would order it for the care of that patient, irrespective of them getting surgery, then that's probably a good indication to get it in the perioperative setting. If you would not get this test for that particular patient and their clinical circumstances, except that they are going to surgery, then that's probably an indication that the test is not needed. Oftentimes, we are aware that these panels of tests that we order in the perioperative setting without clear indication lead to unnecessary cascades. And these cascades could be trying to chase down red herrings that we find in the lab. Ooh, why is that hemoglobin just a little bit below the level of normal? Oh my goodness, your coagulation studies show your PTT time might be a little bit up. Let's do some advanced studies to try to figure out why that is, the case. I do like the saying that, kind of older habits die hard. I think it's hard for us to let go of that level of control that, if I know the white count is fine, that there's no coagulatory disorder issues, that their other laboratory parameters are fine. I've done everything possible to say that the patient is not going to have an adverse event with surgery. And while that might be true, I think what we don't always appreciate is that maybe we cause harm before they even get to surgery, because doing all these tests do have significant cost implications for our healthcare system. But also, in some cases, it delays a procedure for us to only find out that this issue we were chasing was never an issue to begin with. I can remember a case I had of a patient that had an elevated partial thromboplastin time. And because it was elevated, the surgeon asked that we essentially do all the workup to figure out why. And we figured out that the patient had this weird inhibitor that, when you look at studies, there is no particular effect on bleeding with them having this inhibitor or not. But what did happen was the patient went another 3 to 4 weeks without treatment of their neurosurgical issue, because we needed to make sure that this bridge was crossed. So when I think of labs, again, if it is something you would get for your patient outside of them needing surgery, then I believe it's indicated in the perioperative setting. If it's something that you would not get at all, then I would strongly say consider not getting these particular tests, because again, getting tests when we don't know what we're going to do with it not only puts our patients at risk, it really puts us at risk as well.
I think there are too many times that we jump and start doing studies and everything else because that's the way we always did it. And I don't think a one size fits all. If you have a 18-year-old who's going in for, say, minor procedure compared to someone who's going for bypass surgery and has 16 coincident diseases, that would certainly make a difference between them.
Absolutely.
The operative area. This is an area, obviously, where surgeons and anesthesiologists have their great green sheets and everything else. What can the internist or the family practitioner do to really maximize their patient's operative stability?
In terms of operative stability, I think we as internists often encounter patients that are at high risk for perioperative pulmonary complications. And so in doing our perioperative risk assessment, being able to let our surgery and anesthesia colleagues know that somebody has a high stop bang score, and to be careful in monitoring them both in the OR as well as outside the OR for signs of hypoxia due to their underlying sleep apnea can be a great tool for our surgeons and for our anesthesiologists, to know ahead of time. I think in terms of other operative stability is just really taking a long look at the medications that our patients are on and making sure that those that should be continued in the perioperative period are highlighted and noted so that it is clear. I think nothing is worse than knowing a patient has known heart disease and they were on beta blocker therapy, and for whatever reason, it wasn't communicated and that beta blocker was not continued in the perioperative period, and they then have some adverse event. And so really being judicious, looking at that medication list, seeing what meds can be continued, seeing what meds should be stopped and how long they should be stopped. For example, while most meds can be stopped about 24 hours before surgery, as we're starting to use medications such as the SGLT2 inhibitors more, those medications actually need to be stopped about 72 hours before surgery because you would be actually at higher risk potentially for glucose dysregulation and potentially hypoglycemia and other events during surgery. So being able to know those things and be able to, again, essentially co-manage with our colleagues, the surgeons and the anesthesiologists, again, doing those things helps to improve the likelihood of a safe operation and then getting out of that operation and then going into the postoperative care mode.
Okay, and finally, we know after surgery, a lot of times the primary care person, the hospitalist, the internist takes over a lot of the care.
Mhm.
And I remember vividly as a lowly medical student seeing a surgeon chastise somebody because they had a little bit of a fever, and so the intern just ordered a blanket set of blood cultures, and that surgeon chewed him up one side and down the other. And so, what's the right way to look at some of these patients without, doing things that are just basically shotgun and almost knee jerk?
Yeah.
How do you handle that?
I'll be honest, I think we all kind of struggle with this. We don't like abnormal numbers. And I think nobody after surgery likes to see that fever or that new white count. But I think we should all take a step back and recognize that surgery in some sense is like organized trauma to the body. Like there are, multiple incisions, there is blood loss, like there is a lot of things that mucks around with the body's normal homeostasis. And so I always just try to remind my residents and things to look at the patient first. If a patient has an isolated fever, but they're breathing well, their other vital signs are stable, their surgical wound looks good, most likely we could probably say that that fever could just be transient from, I don't know, you just had an orthopedic surgery and they took some screws and other things to your bone and that released cytokines that cause, your temperature to be elevated. Or the same for that white count. My white count would be high if they took and, did an operation on my shoulder and then I'm coming out of the OR and you're checking my blood work, the next day. So I think it's first just taking a pause and recognizing in and of itself that surgery can have various, the body's responses to surgeries can, be very varied. I think a second way to look at it, though, is again to think about a systematic approach. And so some of that is, for example, giving up the idea that fever is due to atelectasis. As a medical student, I was taught if they have fever in the first day after surgery, it is from atelectasis. And if you go back and look at those studies from the 60s and 70s, you'll find that probably was due to a lot of other things. So again, just keep a broad differential. Is it something in the lungs? Is it a new pneumonia? Is it a surgical site infection? Is it a drug that we are giving? Have they developed, unfortunately, a DVT or a PE? So keeping a broad differential and again, asking, that history and doing that dedicated exam, I think can help us avoid shotgun labs and kind of this, approach that is not nuanced and can lead to harm by iatrogenesis.
Yeah, I'm remembering the 5 W's that I was taught way the heck back then. And so sometimes maybe revisiting those and saying which ones are, do we overemphasize and which ones do we need to take a step back from, I think makes a lot of sense. Well, I think this is going to be a very interesting subject. I think it's one that will pertain not only to the primary care people, but of the specialists. And I think that I'm very much looking forward to hearing this. We hope that you all will come out and join us at our meeting in Orlando, either live or virtually. I think this will be one that every single person that's listening to this will find a pearl or 3 to take back to their practice. I want to thank you, Dr. Jackson, for the chance to chat about this. We look forward to seeing you in Orlando, and we hope that we have a whole lot of people coming out to join us.
Thank you all so much for having me on the podcast today. And I look forward to continuing this conversation about optimizing perioperative care for all of our patients in Orlando.
We hope you enjoyed the practice of medicine. For more episodes in this series or SMA's The Business of Medicine podcast, go to sma.org/podcasts or subscribe to us on iTunes, Google, Spotify, or wherever you get your podcasts. For more information about SMA's mission, please visit sma.org. And thank you for joining us.